So let's go about, talk a little bit about the pharmacomechanical. So definitely they play a role, and we know that for many years. That's a paper from 1983, cardinal paper in radiology at the time, that we've seen that streptokinase was effective in causing declotting in blocked dialysis fistulas. It was selectively infused. There was few cases at the time, and lysis occurred nicely in most of the cases with good results. Now, the main question is not whether they work, is whether which one to use and how to infuse it, and whether it should be used with balloon, with mechanical, thrombectomy, or other factors. So we know that streptokinase is not that effective. There's an immunogenic effect. It appears to be the least effective agent. It's not very easy to handle, and there is a significant degree of fibrinogenolysis. So other drugs came in, and these are mainly urokinase and RTPA, and these were papers that were published in JVIR around year 2000. And the delivery method is mainly systemic infusion or direct injection into the thrombus, or prolonged infusion overnight. Depends on the strategy, depends on what each center would like to do in terms of patient management. Now, clearly what we would like to do is to avoid any bleeding, because we know that we do multiple holes in these fistulas, in the dialysis access. We might go from the artery, so we have to consider these factors as potential complications when we give thrombolysis. But of course, we would like to avoid also pulmonary embolism, and this is a factor that might help on this direction. So in a paper that compared the two, previously alteplase and urokinase in the blocked fistulas, the retrospective analysis, in 122 patients, we've seen sort of equally distributed in the two groups. What they did for urokinase was multiple infusions through a multi-site catheter with pulse spray method and maceration and embolectomy that followed. Alteplase was also infused locally with a cannula, and then again insertion of sheaths and maceration and embolectomy. And it appears that the results are more or less similar in terms of clinical outcomes. Not great differences in the two groups. However, procedure time, fluoroscopy, and skin dose were significantly low for alteplase, and we know that because alteplase is definitely more easy to handle in terms of drug, and particularly if it's used for a day surgery, overday, or without overnight stay. So urokinase is somehow moving away from that because it has a later onset of action and inferior rate of thrombolysis, especially when not continuously infused overnight. We've seen the paper from Panos and his team in this. He's gone through that, all that, but we've seen very good outcomes with not a lot of failures, but and a minor complication. What we have to say is that the use of this technique might require a little bit of manipulation, but the outcomes were very good, particularly with the use of drug. Now, if somebody doesn't want to do this manipulation, and this might require a big breakfast to do all that, so we can go through the artery, and this is a transbrachial approach for declotting, and this is a paper between a group from China and US. So the puncture in this case was antegrade from the brachial artery, forefront sheath, and crossing the occlusion, the catheter was inserted in the proximal segment, and in this case, urokinase was used and was injected initially, and after a balloon and a bit of mechanical thrombectomy, continuous infusion followed overnight. And as you expect, this offered good outcomes in this patient group. So just to wrap it up, we have to say that definitely pharmacological and mechanical thrombolysis removes the clot but doesn't treat the stenosis, and we know that angioplasty alone restores the patency, but the clot is the one we need to treat first. So the ideal management is definitely clot management, angioplasty as the best approach. RTPA is definitely more easy to handle, is something that we're most familiar with, particularly if we wouldn't like to do an infusion overnight. So direct installation may be applied, followed by our maceration, and then the techniques that are used in every center might be double sheath, intraarterial approach, or even mechanical devices that can be used for declotting. Thank you very much for your attention.